We're joined by Professor Roger Chen of the University of Sydney. And Professor Chen, you've been talking about this explosion of new drugs for type 2 diabetes. How does a physician choose the best drug for his or her patient?
Well, I think that's the million-dollar question. There are a variety of medications available, new classes, old classes, and there's a whole lot of factors, I think, which come in to a physician's mind in choosing the first medication and then the second medication or combinations. It's easy with the first line medication because in most guidelines throughout the world, metformin is used first line unless it can't be tolerated, and that's along with the usual lifestyle measures, etc. But what's more complex is what's going to happen next, and that very much depends on the individual in front. I don't think there are any hard and fast rules. One of the new, guiding principles now is that if someone has had a history of heart disease or is at high risk, then perhaps one should be steering or leaning towards drugs or combinations of drugs such as the SGLT2 inhibitors or the GLP-1 receptor agonists. Both of these in the last few years have had large-scale cardiovascular safety studies which in fact have shown that they have a favorable effect on the patient with established heart disease. For example, with the SGLT2 inhibitors, the first of these studies was the EMPA-REG study with empagliflozin. And interestingly, in this population of people with established heart disease or established vascular disease, if you took or you're on empagliflozin, you had less chance of dying and less chance of heart failure, and your combined risk of having a heart attack or stroke, and these are non-fatal, and cardiovascular death would also reduce. And the same for liraglutide in the LEADER study, which is liraglutide is a GLP-1 receptor agonist. So that's an injectable with similar findings, except there was no benefit on heart failure, and there are a few little differences. But what happens with a patient who is not, with established heart disease? Well, we don't have that data at the moment, but we may very, very soon. But then we have all these other drugs. We have the old, we have the new, we have metformin, which has been long-standing. We had it for more than, 60 years now. We've got sulfonylureas, which are still very much part of the therapeutic, regimen in many parts of the world, Asia, Africa, Middle East, etc. These have been long-standing, they're relatively cheap, they're relatively available, but they do potentially increase the risk of hypoglycemia as well as weight gain. One could argue that the newer of these agents probably won't do that as much. So it's not that easy, it's not just picking a drug from each class. It's often trying to combine them together or picking one which suits the patient, and every patient is different.
So you've presented us with a really positive picture, but every drug has a downside. Mm-hmm.
Yeah, I think that's a very pertinent comment. I tell my students and registrars who we teach that you have drugs which can potentially save lives. So they're not drugs that you can dish out and leave patients to take. You have to warn them about potential precautions. And for example, with the GLP-1 receptor agonists, there are fantastic medications for weight loss. They're good for heart protection, etc. At least liraglutide and semaglutide are. But the problem is that they can cause a bit of nausea at the beginning, so you have to talk patients through that, and that usually settles down. The exception maybe are the DPP-4 inhibitors. They are generally placebo-like in their side effect profile. They're safe to use, they drop the HbA1c slightly, and they're very safe to use in the elderly. They have to be perhaps dose reduced with kidney disease, and with some of the large-scale studies, there was just a hint of heart failure with one or two of these medications. But it's interesting, you have to weigh the pros and cons, and you have to really spend time and talk to patients about what are these so-called ups, these are the benefits, and what are the downs.
So, looking to the immediate future, it's a matter of using these drugs more effectively rather than seeking still more new drugs?
Oh, I'm sure there'll be always better new drugs. I love that question, because are we where we want to be? No, we're not. We've done nothing to stem the rise of diabetes, so we have nothing to prevent diabetes from happening effectively. We have nothing which potentially will halt the progression of the disease. We know that lifestyle measures such as weight loss and bariatric surgery might do that, but we don't have anything for that. We're kind of dealing still with the endpoints. We're dealing with mopping up the mess, if you like. If someone has heart disease already, yes, this drug may prevent further damage from happening, or it might prevent damage from happening a bit earlier, but we don't have anything which will actually halt it, to stall it, to prevent it from happening. So I think we're a long way away, but we're certainly a lot better than we were 10 to 15 years ago, when the horizon, I think, was horribly depressing. We had drugs, we had combinations, and nothing seemed to be, if you like, that effective. But now we have these new ones, which certainly are a lot better. But we have a long way to go.
Professor, thank you so much.